Welcome to Perspectives on Step Therapy in Oncology. I am Kristina Rua, Director of Oncology Navigation for Sarah Cannon.
I'm Lee Schwartzberg, Medical Oncologist and Medical Director of the West Cancer Center in Memphis, Tennessee.
I'm Rafael Fonseca. I'm a hematologist at the Mayo Clinic in Arizona and chair of the Department of Medicine.
And I'm Jacob Kettle, Oncology Clinical Pharmacist at the University of Missouri in Columbia, Missouri.
So today we're going to be discussing where step therapy has had negative ramifications. And we're going to start with the story of a 68-year-old female who was diagnosed with cervical cancer. She had a past medical history of diabetes and had experienced hyperemesis in pregnancy. She was going to be getting treated with cisplatin and concomitant radiation therapy into the periaortic. So we knew that she was going to be experiencing a fair amount of nausea. Physician prescribed Aloxi as supportive care, but the insurance did deny it, saying that she needed to fail Zofran prior to being prescribed the Aloxi. She was started on her treatment, and after course 1, ended up admitted in renal failure in DKA in the ICU. We obviously had to deal with the issues, and maybe you guys can help kind of dive into the perspectives on how it would, you would have treated it potentially differently so that the patient would have had better outcomes or that we could have changed something.
We might take a step back and just talk about what step therapy is.
Correct.
And what happened in this case. So the patient's insurance company basically dictated part of her care, and in this case, her supportive care.
Correct.
Which was inconsistent with what the prescriber, the provider, had ordered.
Absolutely. Absolutely. So the physician, obviously, because of her past medical history, had focused on what would have been beneficial for her treatment. And because of, we assume cost related, the insurance requested that we do an alternative for, something that we considered substandard care. Despite trying to appeal and whatnot, the insurance did not cover it, and she was started on the Zofran as the insurance requested, and obviously had a negative outcome by being admitted from severe nausea, vomiting.
Right.
From the treatment.
Just to expand a little bit and for the audience, the whole concept with step therapy, of course, is built on the premise that, is there a way that we can escalate, namely starting with medications, interventions, or whatever procedure it is that will incur cost, with something that is less expensive versus more expensive and usually newer. And obviously the framework is set to say, well, let's not be wasteful. But I think one of the things we want to discuss, and this comes clearly through your case, is the idea when trying something like that may not necessarily result in the best outcome for a particular patient.
Well, and you mentioned wasteful. So obviously we know that potentially having that Aloxi as the supportive care initially could have prevented a prolonged hospitalization, ICU, obviously issues that arose for the patient. So is it beneficial? Is it really truly preventing waste, or are we kind of, in essence, worsening our healthcare costs by
Of course.
cutting?
And I think in this conversation, one has to be, for the lack of a better word, holistic, right? So you want to look at the whole episode of care, ideally the whole care for that patient, for that particular diagnosis. So this is an example where something relatively minor could have had significant implications downstream for what ended up being major expenses. Now, in the ideal world, we would have first the decision-making process, be made by the providers, by the physicians, but also have the full understanding of the economics of all of that. And I think this affects people in different settings, particularly, closed settings, and for the payers. So it's certainly not something easy, but from the physician side, we want to make sure that patients have access to the proper, necessary, and best therapy possible.
And we really don't want to use therapies that are expensive just for the sake of that, or new therapies. We always make a personalized approach to a patient. And one of the problems with step therapy is this concept of fail first. And that's exactly what happened to your patient, with disastrous consequences. So the issue here is, what is the evidence base for any particular therapeutic decision? In this case, it's a supportive care decision. And in my opinion, something I do research on is antiemetics, so quite familiar with this. There's very clear evidence that for the 5-HT3 receptor antagonists, that Aloxi, palonosetron, is a second-generation medication, and when used alone or used with corticosteroids, that
Right.
it is preferred. And in fact, NCCN guidelines clearly state that for this particular situation, it's a preferred agent. And given the fact that your patient specifically was at high risk based on her history, the provider made, in my opinion, a good choice and a justifiable choice. And it should be a process of thinking about, for each individual patient, what's right based on the evidence. Sometimes there might not be a distinction, and a lower cost agent would be perfectly appropriate.
Correct.
This is a good example of a patient who was at high risk and therefore should have had the most effective drug.
Well, you mentioned NCCN guidelines and evidence-based practice, and what should have been truly, in essence, the standard of care was to have started the patient on naloxone. But Jake, do you find that sometimes in pharmacy, the guidelines aren't necessarily what the insurance companies are selecting, or how is it that they have decided to say we're going to choose Zofran over Aloxi, even though there is evidence-based practice?
Right.
Like Dr. Schwartzberg
No, it's
said?
a great question. In your case is one, I think, where our practice would be to try to find, especially when something's so clearly justified, guideline-based, evidence-based, and especially in your case, patient factors that really necessitate that escalation of care. We would try to find whatever mechanism we could to get the patient that drug. For the most part, we don't really come across cases very often where something is so clearly outlined, be denied by the insurance company. I think in most cases, you can find maybe at least a shred of a rationale for, their cost savings initiative or those kind of pieces. But, in those instances, that's really difficult to manage when you have that really strong clinical conviction, professional conviction, and then the science is behind you as well. Those are some of the most difficult cases to deal with. Just curious if you all experience the same kind of cases, even whether it's supportive care or even therapeutic molecules, if you run across that in your practice.
Well, I think your point is excellent, and I was just going to speak on your last statement on supportive care, because I'm so glad you chose this case. We're not even talking right now about primary therapy, right? We're talking about adjunct therapy that sometimes is as much as life-saving as it can be because it prevents a dreaded complication. And I think it's a great example of how we can go down to the nuances. I think your point is good. We, in general, have the perspective that there's some rationale for why one choice might be better than another. Now, there's going to be always a tension between the desire of having some algorithmic approach where for an institution, a system, a payer, they can say, oh, I'm going to be able to predict this is what's going to happen. But we all know in the real world, everyone is an N of one, right? Now, you can say, well, how often is that guideline going to be aligned with what I see in the practice? Maybe someone would say, I'd like to see it 80% of the time be aligned. But the reality is it's very tough. And that tension would always be there because I think we as treating physicians see nuances in the history of the patient, their symptoms, their personal preferences, their tumor type that are going to make us make slightly different choices for every situation.
Yeah, algorithms are great for a nice guideline to be a starting point. They're a great baseline.
Exactly.
But they don't replace the clinical judgment and the patient-specific factors. And I think especially supportive care, in addition to just outcomes, it's also their experience. This patient, you bring up in your case, had a horrible experience that really wouldn't be what we would desire to provide as providers. That's not the kind of patient experience we want,
Well, when we talk about the algorithms say that potentially she may not have failed, so we don't necessarily know if she was just, the one unlucky person that didn't respond. But with evidence-based, that we kind of know that based on the algorithm for her case particularly, that there is a heavy chance or a strong chance that the treatment wasn't going to be indicated. Yeah, exactly.
She might have not responded to palonosetron either.
Correct.
And those are the limitations of evidence-based medicine. So I think that is where, in the mindset of step therapy, if you skew so heavily towards a very strict application of evidence-based medicine, or trying to tease out any kind of way to use less expensive therapy, you can run into that. And that's where, again, I think as clinicians, you do feel limited by those aspects from the third-party payers, is when you can't apply those nuances based on your experience.
And that's really the key. I'm certainly not opposed. I doubt any of us are opposed to algorithms and guidelines and pathways, but each patient is specific, as you said, and we have to be able to make exceptions and have flexibility. And the problem is
and apply it timely.
And apply it timely, which is the biggest issue, because going through a step therapy process and trying to get a different drug is a very onerous process. Yep. in my experience anyway. Yep. It involves lots of our staff, and it's difficult to do. Yep. And sometimes the easy way out is just say accept it. And to do this with every patient would be untenable. We could not go with every single patient that is part of a step therapy program in cancer and remain in practice. We just don't have the resources to do it, which, to be honest, I think is part of the principle of having it, is that you're not going to fight it every time. And so it plays to the insurers or third-party payers' advantage there, because it's a difficult process.
Well, and I think at some part it arises, I'm sorry to cut you off, I think it arises probably, maybe not from people in this room, but I'm sure there's cases where drugs were overprescribed, overutilized, and this in large part is probably a response from third-party payers to prescribing practices and trends they've noticed from our community, and so now we're in the position we have to find a way to respond to their response, which is difficult.
So I agree with what you're saying, but when you've got the documentation behind as to why you are prescribing that, I think that kind of strengthens the case. And in this instance, we truly had documentation as to why it was that this was being requested. So it wasn't just at a whim of a physician that was, this is new, so new is better. This is actually something that the patient truly needs and that will benefit the patient in the long run. So even though there's a lot of those physicians that potentially are, well, this is new, this is better, this is a novel idea, let's try this instead. When you have that documentation, and I think maybe that's one of the things that, when the step therapy evolves, that we can start incorporating why it is that this decision is being made, so that you're not taking away the physician's choice to treat their patient, and what it is that has caused them to decide to make that treatment. I think that kind of justifies a little bit more as to why it is that step was taken that wasn't necessarily one that the insurance deemed as appropriate.
Right. Well, and that's why this case in particular is troubling, because sometimes I feel like a lawyer sometimes coming up with a case to justify, why we're advocating for something. But in that case, that we talked about, wow, that's a rock solid argument. Very justifiable, very clinically sound, very scientifically sound. I think those are the cases that, really push us to the brink.
Well, and it's concerning that it wasn't one of these astronomical, new targeted therapies that have come out that, are $67,000 per treatment. Loxy, I don't know exactly what it runs, but it's not a humongous amount, which obviously we know was offset.
The rest of my pharmacy colleague thinks it's very expensive, but for me,
well,
it's not.
When you multiply it by the number of uses, even though it's a different,
but if you offset to see the amount of days, she ended up in ICU. How many did probably one day of the ICU cover the cost of the medication?
Covered 100 patients' cost.
Probably.
Yeah.
So.
Yeah, and that's where probably the division within the third-party payer of their pharmacy resources or those kind of benefits versus hospital benefits, and those probably in siloed departments, and like you kind of brought this up earlier, nothing exists in a vacuum.
Well, I have to admit, I'm very sort of pleased with how we're handling this conversation because of the depth that we're going to the details, because this is very nuanced, right? So it's not like there's an evil party and there's a good party. And I was going to say that a little bit as a preamble, as declaring my in general skepticism of how this can be implemented in a very good way. So I have that perspective, but I do recognize there's all this tension from everyone having to look after the interests and their needs for the unique aspects. I wanted to clarify for those in our audience who might not know that this is different from just your standard prior authorization. It's really a structured that is built so that you have to get drug A before you get drug B, and it's agnostic, or A, B, and C until you get D, something like that. And having thought through it, I can't imagine, just to kind of think about the point and counterpoint. If you tell me for mild hypertension you have to start with a diuretic, I think I can live with that. I'm not a cardiologist, but my first reaction is I could live with that. But if you tell me this is primary therapy for a life-threatening cancer, I have a lot of problems with that. Now, not knowing this is a case we're going to discuss, I'm saying that even for what we might consider secondary, not because it's less important, but because it's not the core aspect of what we do with therapy, which is the supportive care, you're bringing a case where it has profound implications for what's happening to a patient.
Well, it's interesting that you address the whole, for other illnesses or other chronic diseases that for some reason, because we're not necessarily engaged in the management of it, to us a diuretic for somebody that is hypertensive would make sense. But, when we get into our own patient population, it kind of affects us a little differently. But I think it's the severity of the diagnosis and how, when we're talking about failure means toxicity, disease progression, or whatnot, a lot of the times it's irreversible disease progression in our patients.
Yep.
And at that point, we've gotten to a point where, have we really benefited the patients or not, truly?
So truly, supportive care has been considered on a lower level here, and that's one of the reasons that in oncology, step therapy actually began with supportive care drugs. But now it's starting to move into the therapeutics where the stakes in general for every single patient are even higher. And that's a real problem, I think. I think we'd all agree that healthcare costs too much, the rate of rise is unsustainable. We all need to be thinking from a population basis on how we can control costs. But at the individual patient level, is step therapy the right approach, and does it interfere with our approach to deliver personalized medicine to all our patients, personalized care? And it's not that the concept is wrong, and I totally agree that there are areas we could all agree. It's the execution of the process. Oncology is changing so quickly that who makes these decisions and where are the resources at a insurer level to keep up with all the data and to change these processes in a timely fashion, the way that we're all challenged to do when we're taking care of individual patients.
Mm-hmm. Yep, absolutely.
To me, that's one of the biggest challenges.
Yeah, no, I think we're in a time frame where the pace of change is unprecedented. And I think in medicine, not just oncology practice, but the pace of change we're exposed to. And, for us to keep up as clinicians is one thing, but for an insurance company to keep up. And the real challenge, I think, is being able to, I like your phrasing, execution. That's the real challenge. The concept, I think, has its merits. We do have limited resources. We are very expensive therapies. We do have to find ways to provide them, ensure, everybody that's on that one insurance plan still has coverage and there's still drugs. So that's a major issue. But how do we execute it in a way that, provides enough time to get that patient into the infusion center, get them treated quickly? That's the biggest challenge. If someone needs to get treatment, but you have to wait 2-3 weeks for a turnaround, and then maybe you get your denial, and then you got to appeal it, and that's a major issue. Well, think of the stress the patient's going through.
Thank you so much, Jake. You touched on some great topics, as well as you gentlemen, and I think we've really been able to discuss how step therapy, in the case that we have gone over, had a negative impact on the patient, and the ramifications were not truly what the physician had wanted. And I look forward to discussing these further on the rest of our series, and thank you all for joining us.
Thank you.
Thanks.
Thank you.